Okay. All right. So, hello everyone. This is Darshan Mickey. I'm reviewing or going over the content for exam for review. And this session is being recorded. So I'm going to cover the content and answer any question pertains to the content under the endocrine system and the oncology, focusing on the breast cancer, endometriosis, and dysfunctional uterine bleeding and hysterectomy. So let's start with the endocrine pituitary gland. So the I'm, I'm reading from the slide. The acromegaly, which is when there is an extensive, which is a sign of or manifestation, or you can also call it as dysfunction and or disease, or but it's um, unusual overgrowth of the bones and the soft tissue due to or response to the excessive secretion of the growth hormone, which is a sign of the hyperpituitarism. The club fingers, fingertips, large feet, all of that is expected in patients with acromegaly. And we went over this in class to differentiate between the acromegaly and the gigantism. So hypophysiectomy, one of the most, I would say, most effective um, treatment or management for patients with hyperpituitarism due to that, if there are given that the diagnosis is based on the tumor affecting the pituitary gland, which has resulted in the hyperpituitarism, then the patient will undergo a surgical treatment or procedure called hypophysectomy. In that case, either patients are going to undergo, so hypophysectomy means either removing the tumor affecting the gland, but most of the time it's really difficult to remove just the tumor. So they would remove the tumor and the pituitary gland. So the post hypophysectomy, so pre hypophysectomy, um, the client will go. Most of that is patient teaching. We teach the patient about the post, what to expect post the procedure, surgical procedure. So we are going to test, test for serious complications of CSF leakage. So we're going to test for nasal drainage, test the drainage for if there's any clear drainage from the nose or ear, or most of from the nose, is going to be to test the glucose content of that drainage. And if that's positive, then that's definitely it's a CSF fluid and it's not just drainage or secretions. Also, if you remember from the TBI, that we check for a halo sign, a yellow, light yellow drainage from the nose or ear, or a halo, what's called, a halo effect on the dressing. Because patient will have the dressing. I'll talk about the dressing in a minute. Is that this dressing and the nose, which is nasal packing or nasal pack or mustache dressing, it's all it's kind of synonym for the same thing. But and the positive halo sign, that is the indicative or a sign of a CSF fluid leakage. It's very similar, it's the same concept we went over or when we covered the patients with TBI and CSF drainage and halo sign. So again, most of pre-op would be teaching the patient for expectations for post-op, things to avoid, things to maintain, things. So that deep breathing is important post-op. However, that coughing, we know that post-op, like in fundamentals, we teach patients post-op, deep breathing and coughing. But however, for this procedure, coughing should be avoided to prevent CSF fluid leakage due to that, which was result from that. The suture line will be like open. So Post-trans phenoidal hypophysiectomy, we are going to monitor the patient for signs of other than the CSF fluid leakage or halo sign and positive glucose in the drainage, but also we will monitor for signs of meningitis. Knuckle rigidity is a significant sign of meningitis. So the absence of this or the presence of knuckle rigidity of the neck, that is a sign of meningitis, which is not a good thing. So we have to go over meningitis and review the manifestations of meningitis, other than the knuckle or neck rigidity. So also the client must take care to avoid activities that can increase the ICP. Same thing, you go over the TBI or patients with increased ICP and look for on review all of the manifestations of increased ICP. And they also should avoid bending from the waist and should not veer down, coughing, lying flat. It's not good. So it's not recommended. High phallus position, head of bed elevation, 30 up to 45. That's always good. And also think of that ICP post-op. The nasal packing, which is other name would be like mustache dressing, that it will be under the nose for up to 3 to 4 days post-op, will be in place, like should not be removed, should not be touched, always be dealt or taken care of by the surgical team, and should not be ever changed without the healthcare providers or surgical surgeons order. So again, we said about the elevation of the bed of 30 up to 45 degrees. And that's the most important thing about the the transphenodal hypophysiectomy, in terms of about the dressing, about the ICP. Now and this is a form of hyperpituitarism because that's an acromegaly or gigantism or tumor affecting the pituitary gland, in which there is an increased growth hormone, and so that tumor should be removed surgically. There's other forms of the hypopituitarism, which a sign of would be decreased production of ADH hormones, like diabetes insipidus. That would be a form of the hypopituitarism. SIADH is a sign of hyperpituitarism because there will be an increased ADH hormone production. And about the DI and SIADH, you would go over the content, differentiate between or compare between the manifestations of DI versus SIADH, in which that the patients with diabetes insipidus, they will have a fluid loss, which is diuresis, diluted urine, large amount of diuresis of urine to be diluted, and the blood or serum to be concentrated. And this applies to the blood and urine when it comes to concentration, electrolytes, water, either loss or overload. So if you master the DI, you easily can predict the SIADH in terms of manifestations and even treatment. So that's the DI versus SIADH. Now the medications like vasopressin or octreotide, Sandostatin, these medications, they act to result in a contraction or vasoconstriction of the smooth muscle in the vascular bed, um, and constrict the preportal splanchnic arterioles. That's why the sandostatin is good for patients with liver cirrhosis with esophageal varices, because it constricts the blood vessels, and decrease the blood flow to the organs. So the sandostatin will be also provided or given administered to patients with brain tumors, because it will shrink the tumor that way. So the SIADH, for example, because there's an increase and massive amount of ADH hormone produced. So the increased ADH hormone anti-diuresis is going to retain fluids. So patients will retain fluids. So the increased water reabsorption that occurs with SIADH will result in fluid overload, and that can dilute the serum electrolytes. In other words, that large amount of fluid retained in the vascular system with the same amount of sodium, so patient will develop hyponatremia. So they have what is called, or develop a condition called dilutional hyponatremia, and this is the rationale behind that the patients with SIADH, even with the fluid overload, they do not develop edema, or especially like pitting edema, compared to patients with fluid overload like ESRD or CHF. So our aim here is to limit the fluid intake, to reduce the overhydration by limiting the fluids and increase urine output. So we're going to limit fluid intake and increase diuresis. Now, so the SIADH, they're definitely will be at risk for hyponatremia. So we have to supplement patients with sodium to maintain it within range. So serum sodium to be within range. And electrolyte imbalances with hyponatremia, less than 135, it's hyponatremia. But it's not until that the serum sodium level is less than 120 milliequivalent per liter that would increase or predispose the patient, or would increase the risk for complications, like patients may end up with or develop attacks or seizures, and that requires intervention. Malignancy, especially small cell lung cancer. There are different types of lung cancer. This one form called small cell lung cancer. It can cause SIADH also, as etiology for SIADH is malignant tumors, especially lung tumors of that type, which definitely is going to result in increased reabsorption of fluids and dilutional hyponatremia. Adrenal glands. The two glands are located on the top of the kidneys. So with adrenal glands, patients either develop Cushing's disease or Cushing syndrome, or Addison's disease. So Addison's disease, the decreased cortisol, and Cushing's is the increased cortisol. Addison's disease, cortisol replace. So patients with Addison's disease, because they do not have a sufficient amount of cortisol, so they need a exogenous replacement, synthetic cortisol replacement, which is a steroid, especially if they develop the Addison's disease after a surgical treatment, sometimes because of the tumor, they end up with, or surgical team decide that the patient should undergo a bilateral adrenalectomy. So adrenal gland, surgical removal of the adrenal gland patient should, so post-op, after the surgical excision or removal of the adrenal glands, both of them bilateral, then patients should be receiving the lifelong cortisol replacement therapy, and they will be on a daily um, basis kind of treatment for the rest of the client's life. So, can the patient skip doses? No. Patients skipping doses could cause adrenal crises or adrenal insufficiency. In other words, patients with Addison's disease or patients with adrenal gland tumor post removal of both adrenal glands, they end up with Addison's disease. But to prevent the Addisonian crises and Addison's disease symptoms, patients should be receiving the daily dosage of cortisol replacement therapy, which is a steroid. Now, if the patient skip any doses, then that could result in adrenal crises. But can the patient take more or like a double dosage? Yes. If the client cannot take the replacement by mouth, we can also do arrangements that patient can receive the parenteral like IV or so. But however, the patient should take that steroid on a daily basis to prevent the adrenal crises or Addisonian crises. Now, when would the patient and they will be taught, they will be given or provided with a good like educational sessions about the steroid, their side effects, about which should not be skipped, but they can sometimes increase the dosage, and they will teach them about how and how much to increase the dosage, double it, or but they will give them a good teaching. It's an individualized kind of plan. So the need for hydrocortisone, for example, which is a steroid replacement, if the patient like on a daily hydrocortisone medication, that can be they know when there is a need for that replacement to be increased, sometimes to double the dose that day, with some conditions. With they will list them several stressors, such as illness. They are like, an acute illness, infection. They are in high stress, like, life. Personal, like, issues or problems, or they have like, so stressors of all types, stressors or de-stress, stress of all types, they will be taught to increase the dosage and sometimes to double the dose that day, especially when they are under stress. Other indications that based on patients' manifestations to increase the dosage is, for example, we know that the Addison's disease, everything is low. Blood pressure, heart rate, everything is low. Respirations as well. So the indication would be like manifestation to increase the dosage, the decreased blood pressure, because it's a sign of adrenal insufficiency or adrenal Addisonian like crises. Decreased blood pressure, like less than, like I would go with 100/60. Any number less than that, they should increase the dosage. Heart rate less than 60, same thing. So these are the conditions in which that patient would be provided, like in the patient education to be very clear to the patient when and how much to dosage to be to double it or to increase it. For example, if the patient like on 20 milligrams of steroid or decadron, doubling means 40. If they want to go like higher 1.5 dosage, this will be like 30 milligrams daily. So again, it's an individualized plan, but they should be provided with a clear, easily with like with no without using any medical jargon to understand the concepts or the dosage and how much and when to increase the steroid replacement therapy.
Wait, Professor, I have a question.
Yes.
So let's say a patient's blood pressure is lower than 100/60. you would increase the dosage because they can go into like Addisonian crisis.
Yeah, low. Yeah, this is just my numbers. I mean, I go with the blood pressure medication with 100/60 and 60 for heart rate, but you can, it's very again, it's very individualized plan. So it depends on how how that patient's blood pressure and heart rate runs, and we'll go from there. So that's why I do not like stress much on numbers because I don't want
Mm.
to put that 100/60 to be like, like a template for like, everyone to follow. But again, it's very individualized plan, which means that it depends on how, how that, the patient's heart rate and blood pressure um, daily. We usually have a graph and look, we do some analysis and to find out about how much to give. But usually you don't have to stick with numbers.
Okay.
Yeah. So the proper use and discontinuation of cortisol therapy. Patient on steroids for many conditions other than the Edison's disease. There are many indications for steroid, and we went over this in previous content or system. And patients who would undergo the organ transplant, they will be on immunosuppressant therapy, and one of them is a steroid. That's an indication. Patients with SLE, patients with rheumatoid arthritis, patients with other chronic diseases will be on steroid. So the long-term steroid is not just only meant to be prescribed for patients with Addison's disease, but there are other indications, long list of indications for patient to be on steroid therapy. It will apply to all these patients. The same thing here about the side effects, about the expected like complications from especially lifelong use of or long-term use of steroid. So read about the why it's recommend. We do always recommend to taper off the steroid medication in terms of like not lifelong will be for those who would receive it for like short-term, short amount of time, like over like 7 days or 10 days or a month or two. We always have to taper off the steroid. And I went over, in class, I said that, this can lead to, because the sudden discontinuation or discontinuation of the cortisol or steroid can lead to adrenal insufficiency, adrenal crises, or Addison's disease. So that also steroid, one of the side effects. We always review them in class. Side effects are too many, but we focus on the most significant ones. And the most serious would be the peptic ulcer disease, osteoporosis, immunosuppression, the delayed wound healing, hyperglycemia. All of these are expected side effects from steroids. So as we take care of patient on a long-term or lifelong steroid replacement or medication, make sure that you take care, like nursing care plan should be based on these side effects and how to prevent them. Like for osteoporosis, patients should be on a medications to prevent osteoporosis or to lessen the extent of osteoporosis or the severity of the osteoporosis. Or so they'll be on medications to prevent that. Same thing for other conditions. Sometimes it's just nursing interventions, and other times would be medications to prevent the complications. Hyperglycemia. So I would recommend that you go over the side effects and the management for each one of these side effects. Cushing syndrome. So the Cushing syndrome or disease is which as a result, which usually results from an increased level of cortisol, which would contribute to the excessive bone demineralization and increased level of pathologic bone fractures. This is an example of that patients with increase on steroids. So an important concept here is that when we talk about a patient on lifelong steroid side effects, it's very similar to the manifestations of Cushing's disease or Cushing syndrome. Given that The previous one, this is a patient who's been taking a steroid because of other conditions. And here we have a patient with Cushing's disease, endocrine system, disease, which resulted from the increased cortisol production. Both scenarios or both patients, you can deal with them at the same kind of tactics and same intervention, same the same concept here is or it's just one concept which govern both cases in which that the first patient was a patient who was receiving steroids lifelong and it intended that they should take this medication to treat other conditions. And on the second case, we have a patient who has been diagnosed with Cushing's syndrome. So the side effects of a steroid is going to be similar to the patient with Cushing syndrome manifestations. So you always put, you can place or put both conditions, both uh, dysfunctions as equal in terms of side effects. I'm sorry, manifestations, treatment, interventions, nursing care. So Cushing's syndrome, and we went over different types of the Cushing's disease versus Cushing's syndrome. So it's a disease that has resulted from the increased level of cortisol or steroid, cortisol production for Cushing's disease. And that contributes to, for example, one of the side effects of steroid is osteoporosis. Same thing here. With Cushing's syndrome, we have an increased endogenous um, uh, cortisol, which contributes to the osteoporosis because it will result in excessive bone demineralization, which would lead to a pathologic bone fractures. So that's the link I'm trying to get here is that, both scenarios, there will be at risk for osteoporosis. To prevent the osteoporosis, patients should be on medications. We went over this also in class, the class of biphosphonates, and the side of the nursing care of patients on this group of class of medications, the fluids and the early morning on empty stomach and all of that.
Right.
So and then the patient will be at risk for pathologic bone fractures. But biphosphonate is going to prevent the osteoporosis and the resultant pathologic bone fractures. So patients who miss or who are non-compliant or patients who are maybe undertreated with biphosphonates, they will end up with these pathologic bone fractures. But these biphosphonates are going to prevent to high I would say like and prevent the osteoporosis to high levels or high uh, so the diet also and Cushing's disease. So patients with Cushing's disease or on steroid therapy, they will be at risk for sodium retention, hypokalemia, so hypernatremia, hypokalemia, fluid overload, weight gain, hyperglycemia. So all of this should be taken care or should be considered as we plan the dietary modifications to treat patients with either on steroid therapy, lifelong or long-term steroid therapy, or patients with Cushing's syndrome. Like sodium restriction, make sure that the potassium level is because of hypokalemia, patients, potassium level within range, so that they have to increase their potassium content in their diet and not to drink a lot of fluids and low carb, high protein, and so forth. So that's an example how would you plan the nursing interventions for patients with Cushing's disease, and same as patients on lifelong or long-term use of steroid. The So the pheochromocytoma, um, I believe we covered this in class about there are the content pertains to this. And again, in the book is very limited, so it's just to know the side effect. I mean, sorry, the etiology, which is usually patients with pheochromocytoma develop this condition due to a tumor affecting the adrenal gland, especially adrenal medulla, which will produce excessive amount of epinephrine or norepinephrine catecholamines, and that would result in a significant elevation of the heart rate and a blood pressure, and patient will complain of severe headache, chest pain. Um, the vanillmandelic acid test, VMA test, that's another important test to review and to also review the nursing preparation, like how would you, the patient, things that should be avoided before the test. And I believe I went over this in class, and we had a few questions about that, specific like nursing teaching and the things that patients should not receive or take or ingest before the test to maintain the validity and the of the test. So or accuracy of the test. Now, hypo and hyperthyroidism. So patients with hypothyroid, there are different types of hypothyroidism. The primary type, which result from the pathologic changes in the thyroid gland, and that's in which that the gland cannot secrete the sufficient amount of thyroid hormones, T3 and T4, that would lead to a decrease in the metabolic activity. The metabolism will be very slow, and that's why the patient will gain weight. They will have a sluggish kind of like thinking, and affects their mentation, affects their activity level, fatigue, general weakness. So everything will be kind of slowed down due to that decreased metabolic metabolism. So the patient's appetite would decrease, even though that patient will gain weight, and the patient will have a cold intolerance to cold. The hypothyroidism also, it will decrease the GI motility. Um, and so this is a term or medical term called gastroparesis. And one of the um, parameters that clients can use to determine if changes in the dosage of thyroid, because patients on with the hypothyroid, either that from birth, like congenital, or develop that as during childhood, or due to the old age, because older adults at a high risk for hypothyroidism due to as a part of the aging process, in which that the thyroid gland doesn't provide sufficient amount of T3 and T4, so that metabolism will decline. So regardless of the type or etiology of hypothyroidism, the patient will be on or receive a thyroid replacement therapy, thyroid hormone replacement as a medication, and they will be, there are some indications to determine if the thyroid replacement is sufficient or its patient is undertreated with thyroid hormone replacement therapy. So one of them is the constipation. If the patient is still constipated, that's not a good sign, which means that the thyroid hormone, the replacement therapy maybe has to be adjusted. But we don't just go by constipation, but we will review the lab values of T3 and T4. It's low, and TSH is high. then this is the sign that patient current medication or dosage of the levothyroxine, it's inadequate. Should be pumped a little bit up, should be increased. Another indication other than constipation, the cold intolerance. Patient still feeling like a cold, any like like a room temperature. Everyone else is not complaining of cold, and that's the only person who's called complain of cold. That is going to be another indication that is that the medication is dosage is supposed to be increased. So modification or adjustment of the dosage is based on the patient's, again, signs and manifestations or indications or of the function of that hormone. Again, an example of that would be constipation, cold intolerance. Like when you take, also when you take a patient's temperature is below normal, like the temperature below normal. Activity level has declined significantly. Patient is still sleepy during daytime. Fatigue and all these signs of hypothyroidism, an indication that we have, or we at least give us an indication to or a hint to review the patient's lab values and to do like blood work and to do make sure that T3 and T4 and TSH are within range. Otherwise, we have to increase the dosage. And when would you increase the dosage is that when the T3 and T4 are low and TSH is high. So patients with hyperthyroidism, they need a medication to antagonize the thyroid gland and its hormones, which is an anti-thyroid medications like PTU, propylthiouracil, iodine. All of these are anti-thyroid medications. However, that patients with Graves' disease or hyperthyroidism, after receiving these anti-thyroid medications, they may end up with becoming or developing that hypothyroidism as an outcome or product of kind of condition of being on the anti-thyroid medication for the hyperthyroidism. So hyperthyroid cases receiving anti-thyroid medications, they may end up with hypothyroid. So that's why the hyperthyroidism, usually patients receive the medications for a short, I would say like amount of time or like, short term, and then they will undergo a surgical treatment, which is a subtotal or total thyroidectomy. So the thyroid crisis and myxedema coma, you will go over the manifestations. You'll find like tachycardia, palpitations, high blood pressure, high agitation, restlessness, insomnia. All these are thyrotoxicoses or thyrotoxic crises. Myxedema coma will be the absolute, the absolute opposite to that, as signs of a myxedema coma, which is a life-threatening condition for both cases, in which the manifestations are heightened and that requires immediate intervention. Like for example, patient with the myxedema coma would be indicated with acidosis because they are not breathing enough, right? The rate of breathing is very slow and or very very low. Like patients breathing rate is 8 or 9 or 10. That's in which that patient will develop respiratory acidosis. Blood pressure is like 80/55. Heart rate is 51 or 52. All these are indications that patient is developing a myxedema coma from the Edisonian crisis, and that also should be validated or supported with patients' manifestations like activity level, fatigue, severe fatigue, and generalized weakness, and patients' activity level, and patients' mentation also is very patients like as if they are They are like semi-conscious, lethargic. All these are signs of a myxedema coma. And the worst case scenario, patient will be comatose, unconscious. So diagnostic studies just highlight a few things here about the thyroid scan, in which that patients will receive the radioactive iodine uptake to scan. So this is for diagnoses and differential diagnoses to find out if patient had developed Graves' disease versus thyroiditis. Both scenarios or cases is, also are both are can be listed under the hyperthyroidism. Hyperthyroid, either Graves' disease or thyroiditis. Now, in case and the patients with so this is so this the test is going patient will be exposed to this radioactive iodine, and we'll find out how much the gland will uptake. So the Graves' disease, if that's the Graves' disease, then you'll find that it will be indicated by the uptake of large amount, like 35% up to 95% of the radioactive iodine will be uptaken by the gland. That's Graves' disease. But if only less than percent of the iodine uptaken by the gland, then that's thyroiditis. So the more iodine uptaken or during the test, that's going to be Graves' disease. And in terms of the percentage of patients with Graves' disease versus the other one, is that you'll find that patients with hyperthyroidism, patients will be the percentage of cases of all different types of hyperthyroid, they belong to that Graves' disease. About more than 75% of patients with hyperthyroidism will be of the Graves' disease type. And about like 1/3 or 25% of the other one, which is thyroiditis. So that's what testing about the thyroid scan testing for diagnosing and differential diagnosing. Another test, which is more definitive, more accurate, is going to be the fine needle aspiration test, in which that we aspirate and then we'll send it to the lab for pathologic exam. About the size of the gland, there are two different types of testing. One is called it's like versus called the which is benign nodules with increased iodine intake, and when it's cold, this is like designated like names, either hot or cold. The cold, which is nodules, notes that most likely, not definite, but most likely is going to be malignant with no iodine uptake. That's another diagnostic test for like differentiate between the benign versus malignant tumors affecting the thyroid gland. Now, again, the most aside from the PTU, propylthiouracil, and iodine, radioactive iodine, as a treatment, there is also radioactive iodine I-131 isotope been used for treatment of patients with hyperthyroidism. But that's usually for patients who are not a good candidate for or eligible to be to undergo the thyroidectomy. So either subtotal or total thyroidectomy. No, so this is a procedure we're going to be subtotal or total, is that this is the most, I would say it's optimal, it's most effective, it's going to be more, it is more with less complications, and it's like lifelong, like, it's a great intervention compared to the medications. So talk the ultimate, like, optimal treatment is going to be the surgical treatment for this specific like disease. So the thyroidectomy, either type of the or both types, the pre-op is very important. Pre-op, as we prepare the patient before the surgery, patient will receive medications. One of them is the iodine treatment. So before the surgery, to alleviate the thyrotoxicoses or prevent thyrotoxicoses or thyroid crises, iodine treatment, or and sometimes with PTU will be given before surgery. In addition to also propranolol, which is the Enderal, which is a beta blocker, will be also given to decrease the cardiovascular manifestation of thyroid storm. Because remember that hyperthyroidism, one of the manifestations is tachycardia, palpitations, and increased blood pressure, especially with tachycardia and palpitations. So the Enderal will, or propranolol will decrease that. The one of the radiations which pertains here to the implanted, it's not going to be implanted here, but brachytherapy, but also this applies to the implanted one or intracavity under the endometriosis and the cervical cancer. The same concept. So the intracavity radiation, which is brachytherapy, which is an internal radiotherapy. They use the radioactive isotopes either in solid form or without or within the body fluids. So the radiation source is going to be implanted like within the patient. So the client with is so again, one of the questions always being asked to the patient family and healthcare providers if the patient is going to emit radiation or not, and how long and time frame. So the client with intracavity radiation could cause problems with the, like, especially if you're going to assign this patient to a pregnant nurse or PCA or any employee who's pregnant. That's not recommended. So it's contraindicated. So anyone who is pregnant should not be assigned to take care of a patient with this intracavity radiation. That's the concept behind it. And you can apply this to any type of intracavity radiation if that's for this disease or any other diseases, like in cervical cancer and under endometriosis. And here, I know that doesn't belong to the content, but just to make sure that the mid-surge, we cover this concept, is the treatment that are, or therapies, things that are harmful to the fetus. Brachytherapy is not good for them. Radioactive iodine, isotope 131 is not good for them. The CMV, anyone who is infected with CMV, cytomegalovirus, should not take care of a patient who is pregnant or any pregnant. All right. Just want to admit, student. Okay. So therefore, clients with a same thing is that clients with CMV receiving these therapies should not be assigned to a pregnant employee, right? So these are very harmful to the fetus. Back to the radioactive iodine isotope 131, because this is the specific isotope of iodine radioactive isotope 131 that is very effective to shrink the thyroid gland for patients with hyperthyroid. So that would be, so the radioactive iodine is going to be the treatment of choice for most, again, non-pregnant adults or women. So the pregnancy test is done on all women who experience menstrual cycle before initiation of therapy. So this is one of the preventive measures or things that should be taken care of or done before we start a therapy, to do a pregnancy test to avoid any future or prospective or issues, so, or complications. Because how the radioactive works is that because it destroys the thyroid tissue and it will limit the thyroid hormone secretion. So it will treat the patients with hyperthyroidism thyroidism by damaging the thyroid tissue, decreasing the thyroid cells, releasing the thyroid hormones. Eventually, is going to limit the or decrease the thyroid hormone secretion. Um, Now, the radioactive iodine, one of the little issues with this radioactive treatment modality is that it has a delayed response. This is one of the only issues. It's effective to a high extent or high limit, but it has a delayed response in which that the maximum effect may not be seen for up to like it goes between like 2 to 3 months. So for that reason, while patient is on radioactive iodine, patient should receive or should be usually treated with anti-thyroid medications like propranolol, iodine, the PO form, and the polythiouracil, PTU, before and during and the first 3 months after the initiation of the radioactive iodine until we see a good or apparent benefits from the radioactive iodine, which will be exhibited in patients, manifestations and signs and symptoms. We can stop these medications and rely on the radioactive iodine. And this will be in the case that this patient is not a good fit or not a good candidate for the surgical procedure. Now, pre-op and post-op thyroidectomy. And the anti-thyroid drugs should be, again, taken 4 to 6 weeks before surgery. So this say that this patient is good candidate. It's heavy, like, cleared from the MD, like in PCP or MD clear or surgical team cleared them, the patient for surgical procedure, then 4 to 6 weeks before pre-op, patient should be on anti-thyroid medications. And the most important one is going to be the iodine. The iodine 10 to 14 days before surgery. So the iodine reduces, or what are the benefits of the iodine? Why would you give the iodine before surgery? Because iodine is going to decrease or reduce the thyroid size, or the thyroid gland would be reduced. It will result in a decrease and reduction of the vascularization blood vessels of the thyroid gland. It will decrease and reduce the risk for hemorrhage bleeding post-op. And it will also decrease and reduce the risk for thyroid storm or thyrotoxicosis or thyroid storm during the surgery. So that's the benefit of iodine pre-op. So the iodine, when given PO, these are very important, but this is important nursing implications about iodine therapy, especially the PO therapy. Iodine given PO should be mixed with antidote juice or things that are like, patient's choice. So iodine should be mixed with juice or even water. Can mix it with water too. Step through the straw and should be given after meals. Now, there is a risk that if patient takes too much of this iodine, that they may end up with iodine toxicity. And so it's a very important piece of content here, or to remember for my exams, board exams, about the manifestations or signs of iodine toxicity. The first one, the oral, which is buccal mucosa, swelling, edema, swelling of the oral mucosa and other mucous membranes. Patient's saliva will increase, like excessive saliva. GI symptoms like nausea and vomiting. And very important to remember about the skin reactions. Can be like redness, hives, or there is some type of skin reactions. At any time patient had developed any of these symptoms, that's a sign of toxicity. Iodine administration should be discontinued, and we should, refer to the PCP or refer to the PCP. Now, post-op, we always remember that one of the most important equipment to be placed or present post-op suction, and it's an assumption that patient is in like since been transferred to subacute facility. So suction and ET tube or endotracheal intubation to be ready. So the post-op complications, thyroid gland removal, either total or subtotal. The first one is the airway. So you can start with airway, stridor, and difficult breathing. Patients have completely lost their voice. These are complications, but not expected. This is like that warrant immediate intervention. Hoarseness, again, we said, the voice hoarseness is expected for a few days post-op. The third one is profuse surgical bleeding. Some blood oozing on the dressing, and that's expected. But profuse surgical bleeding, or surgical incision, bleeding from the incision, that's complication that warrant intervention, immediate intervention. Now, remember that we said that sometimes iatrogenic, like inadvertent removal of the parathyroid glands, one or more of them, or the four, that could result in hypocalcemia. And one of the post-op complications that may be presented or exhibited in patients that the patient had developed hypocalcemia, Schwarzschild, Trousseau-Sign, and then signs of tetany and muscle spasm and twitching and all the so review all the and the tingling sensation of the circumaural tingling and paresthesia. All these are signs and manifestations of the hypocalcemia, which indicates that parathyroid glands were removed. So before we go to the parathyroid gland, sorry, we'll just finish with the post-op thyroidectomy. So assess the patient every 2 hours for at least 24 hours for signs of hemorrhage, bleeding, and for signs of a tracheal compression, which is a irregular, difficult breathing. So signs of bleeding, hemorrhage, and signs of tracheal compression, which is from the swelling of the gland post-op, it may obstruct the airway. So that's why stridor is not a good sign, because that's a sign of a tracheal compression by the swollen post-op gland. So you assess every 2 hours for a few things: for irregular breathing, for neck swelling, not just the surgical site, but also around it, like the whole neck is swollen. That's a sign of bleeding. You assess for, remember, recall from OBPs about the patient's post or children post tonsillectomy, the excessive frequent swallowing, it's a sign of bleeding or hemorrhage. That same thing here. Frequent swallowing, excessive swallowing, it's a sign of bleeding also. Also, you'll be looking for a sensation of the fullness. Patient will complain about that. They will know that they have kind of feel they have a feeling of fullness at the incision site. That's a sign of bleeding. Chalking and or blood on the anterior or posterior dressing. So profuse amount of blood, like a large amount of blood on the dressing, that's a sign of bleeding. So all these should be like, done every 2 hours for the first 24 hours because that's the most serious time frame post-op. Now, the patient positioning, you should position the patient semi-Fowler's position, semi-Fowler's position, and support the patient's head with pillows, like around, like both sides. And also avoid any flexion of the neck. And because any tension could result in rupturing or damaging the suture lines. Third one is to monitor the patient's vital signs. Like do the initial assessment. You check for signs of tetany, like hypocalcemia. Very important to know all these signs. Tingling sensation of either circummoral or toes or fingers or on the mouth or muscle twitching or apprehension or restlessness. All these are signs of hypocalcemia. And we said that the hoarseness of the voice, that due to that edema, it may last for 3 to 4 days after surgery. That's expected. And it's not a sign of severe bleeding or even laryngeal injury. So parathyroid gland. The parathyroid gland, I'm not going to repeat the same stuff we went over class, and I mean in class. So this is the same content we went, but just let's review few things here, like for no medications or things that I did not least stress in class. Like for example, we went over biphosphonate, Boniva or Octanil or Fosamax, and the necessary care of patients on these medications. The Sensobar, which is a new class of drugs that increases that would increase the sensitivity of the calcium receptor on the parathyroid gland, resulting in a decreased parathyroid gland hormone secretion and calcium blood levels. So it will, in other words, that is going to increase calcium level and spare the calcium stores in the bone. So patients with who tend to have this hypocalcemia, this medication is going to help them restore the calcification into the bones and prevent the osteoporosis. So drugs in this class are currently approved also for a secondary hyperparathyroidism, like in patients with chronic kidney disease, end-stage renal disease on dialysis. They tended to develop the hyper or secondary hyperparathyroidism, and eventually, because of the pulling the calcium from the bones into the blood, so this Sensipar is going to push that calcium into the bones and prevent osteoporosis by that mechanism of action. Even though that the Sensipar is being approved by the FDA to treat patients for secondary hyperparathyroidism, like in patients with ESRD or CKD, but also it's still under investigation for use in patients with primary hyperparathyroidism. But we know the mechanism of action is that's going to push that calcium back into the bones and prevent osteoporosis. Now, the parathyroid gland removal or surgical resection of the parathyroid glands. So, what are the criteria? Who should, be eligible for this? The good candidate for this type of surgery for the surgical excision of the parathyroid glands, because they are um, being diagnosed with hyperparathyroidism, especially with the primary type, when their calcium level is over 12. That's one of the criteria. Hypercalcemia to the point that their calcium level is over 12. And we should review about the complications that may result from hypercalcemia with calcium level over 12, especially on cardiac complications. Hypercalciuria, when the calcium in the urine exceeds the 400 milligrams per day, or when we do the bone marrow density test and we find a markedly reduced bone mineral density, very advanced case of osteomalacia or patient almost like having osteoporosis. So that's a reduced bone mineral density. And another criteria, when the patient has a apparent manifestations or overt symptoms like neuromuscular effects, or patients had developed a kidney stones, nephrolithiasis, because of the hypercalcemia. And also another criteria, patients under the age of 50. They're all criteria for patients to be considered for the um, surgical removal of the parathyroid glands. The parathyroid scan, so the post-op will be very similar to a patient post-thyroidectomy, like the tracheostomy, the suction, O2 should be equipment that be present post-op or available post-op. Laryngeal nerve damage. So very similar to the patient, to surgical procedure of the thyroidectomy. Um, Now, if all the glands are removed, because sometimes they just remove the affected glands, maybe the tumor affecting only one or two glands or more. But if all the glands are removed, all four of them, due to the hyperplasia, because hyperplasia was, one of the etiological factors, or one of the hyperparathyroidism types, or the pathophysiology is hyperplasia. If all the glands are removed due to the hyperplasia, then sometimes the implant, and this somehow weird, looks seems weird, but that the small portion of the gland will be implanted in the forearm or near the muscle, which is behind the scapula, which is called the sternocleidomastoid muscle. The sternocleidomastoid muscle, which is right behind the scapula, which is the back shoulder muscle, that sometimes they implant the portion of the gland in the forearm or in that sternocleidomastoid muscle. Now, if all maneuvers fails, like patient is not good for surgery, so the patient will be treated with a calcium and vitamin D to prevent the osteoporosis. Now, the hypoparathyroidism. So in this scenario, patient will develop the hypocalcemia. And the uh, the hypoparathyroidism is seen in like patients with ETOH abuse, ethanol alcoholics, patients with the malabsorption syndromes, patients with chronic kidney disease or end-stage renal disease, malnutrition, also may be related to the increased renal clearance of magnesium caused by the use of aminoglycosides. So like patients on aminoglycosides like amikacin, antibiotics, they will have an increased renal excretion or clearance of magnesium because it's renotoxic, the aminoglycosides like amikacin or gentamicin. Um, so the hypoparathyroidism, the manifestations, they range from mild tingling and numbness of the muscle tetany, which is mild to moderate hypocalcemia. But with severe hypocalcemia, then patients will develop or complain of severe muscle cramps, spasm of the hands and feet, seizures, and sometimes psychoses. Severe hypocalcemia, 10% calcium chloride IV or gluconate. Calcium gluconate will be administered over 10 to 15 minutes. This is the most effective intervention for severe hypocalcemia. However, that calcium IV should be infused slowly to prevent hypotension, to prevent dysrhythmias, and to prevent cardiac arrest. Patient on calcium, any type of calcium chloride or calcium gluconate IV administration, patient should be on. So before you start the IV, put the patient on ECG or EKG monitoring device. Now, with the acute vitamin D deficiency, patient will be on a calcium, which is a vitamin D, 0.5 to 2 milligrams daily. Now, you can raise the calcium levels rapidly and as it will quickly be metabolized. So, and most of the time we give both of them combined in one form, like vitamin D with calcium combined. So the severe hypomagnesemia, for example, um, with the very low magnesium level, um, you will give the 50% of the magnesium sulfate, and which is an IM or IV, and it will be given up to 4 grams daily. Depends on the magnesium level. Now, the parathyroid hormone, is there a PTH hormone replacement? No, it's not recommended drug because the expense and the need for parenteral administration is not reasonable. It's not effective. So the PTH hormone replacement is not recommended drug therapy. Now, rebreathing. Rebreathing or the long-term therapy first. The oral calcium supplement will be given at least 1.5 to 3 grams daily in divided doses. That's the calcium supplement. And always remember that calcium supplements should be combined with vitamin D. Now, there are some when we teach patients about dietary recommendations and patient teaching about diet, the foods that may reduce the calcium absorption. So calcium absorption may be reduced, um, like foods that contain oxalate or oxalic acid, like spinach, okra. Um, Food that is high in phosphorus, like legumes, nuts, also they may reduce the calcium absorption. Whole grain, bran or whole grain, also that also may reduce the calcium absorption. Now, rebreathing, which is one of the most sophisticated mechanism, how rebreathing can reduce, um, or I'm sorry, can help with hypocalcemia or increased calcium level in the blood. Now, the rebreathing, it can partially, again, we cannot just rely on rebreathing as a sole only treatment for hypocalcemia, but it would be one, sup, supplemental and, addition to other management or interventions. So rebreathing can partially alleviate acute neuromuscular symptoms associated with hypocalcemia. It can alleviate generalized muscle spasm, mild, mild tetany, or hypocalcemia. So if you instruct the patient to breathe in and out, if there is a breathing mask, you can use a paper bag because this technique of breathing in a paper bag or breathing mask, it can reduce the CO2 excretion from the lungs, increase carbonic acid level on the blood, and lowering the pH. In other words, you make the blood acidic. So the low pH acidic environment or blood becomes acidic, it will enhance some degree of ionization of the calcium. And the ionization of the calcium, that's going to increase the proportion of the total body calcium available in active form. Because remember that we said that the calcium, we half of it, 50% inactive, and 50% ionized, the active form. So this technique will increase the ionized calcium, and this will, again, temporarily, while, for example, waiting for other interventions, medications, techniques, but it will temporarily relieve the manifestations of hypocalcemia. Now the oncology, the breast cancer, endometriosis, and uterine bleeding and hysterectomy. Okay, so let's look at the first question. 53-year-old patient asking about, or the nurse teaches the patient about screening for early detection of breast cancer. Statement requires the clarification by the nurse. Looking for the incorrect statement here. Is the SPE, which is self breast examination, is it a form of screening of or treatment? And is it the only method to screen? And is it reliable method to detect breast cancer?
Um, Self breast examination is also good.
So screening for the early detection of breast cancer includes yearly mammograms starting at age 45. The BSE has benefits and limitations and may not be a reliable method for early detection of breast cancer. It can be used to assist or indicate or give the patient the cause to seek medical attention, but not should not be listed as a reliable way to detect breast cancer early. But it should be done in premenopausal. Remember, this is a 53-year-old patient. So, however, that it should be done in premenopausal women right after the menstrual period and when the breasts are less lumpy and tender. So, if you dig into each one of the top three, they are correct. The only one is incorrect is 4. So they remember that premenopausal post versus the postmenopausal. And the language here is that it says it is a reliable way to detect breast cancer early for that 53-year-old patient. So it's incorrect. Next one. Any question about this question? Now, the second one, 29-year-old preemie Paris patient is breastfeeding, 3-week-old infant, complains of recent breast tenderness, redness, and fever. Which teaching point should the nurse reinforce when following up on her care? So when the patient is following up in a clinic or right, so what type of teaching point would you provide or reinforce?
Um, Patient has continued breastfeeding with maybe put warm compresses.
So can continue, right? Can continue or stop? Continue, right?
Continue. That's
Continue, yes.
mastitis.
Because
Continue
this is
because it has to
mastitis.
end.
Exactly. Yeah, yeah. So ensure the patient adheres to the prescribed because the patient will be on antibiotics anyway, right? Because that's the mastitis, right?
Yes.
Yeah. So patient will be on antibiotic, number one. Second is that because this is mastitis that's normally require antibiotic therapy and is closely adhere, so patient should adhere to be compliant with that antibiotic therapy. Now, second, about the breastfeeding should be continued, if possible. So now, what about the tenderness here? It said probably let's see, tenderness, redness, and there's fewer. So what about the tenderness and redness? When would you, in other words, when would you recommend that patients should seek medical attention or like seeking an advice with assumption that this could be a tumor? What type of breast tumor that should warrant attention, medical attention? Based just on palpation.
If they feel any lumps?
Okay. So if a palpable mass develops, then they have to, they have the medical follow-up may be needed to determine if the abscess or is present or tumor. But I have another question actually about the specific changes that should warrant intervention or should, at least should warrant the seek medical attention. About the color, the drainage, the or indentation. There should be another question about that. Let's take a look at the other question. The nurse is teaching a health promotion in health promotion workshop. 2E group of 1 in their 40s and 50s, which information about nipple discharge should the nurse teach to participants?
Professor, are we supposed to see the options?
No. I would like to see what answer do you have
Oh,
for
you,
the
if the patient has
discharge?
like
Yes,
if the patient has like a bloody discharge, is abnormal.
yes. So although most cases, so unexpected nipple discharge of any type warrant medical follow-up. That's number one. Although most cases of nipple discharge are not related to malignancy. Now, all of them, it's associated with malignant tumors, but further medical assessment is indicated. So the other testing would be done for inappropriate lactation before a breast biopsy would be necessary as well. So the bloody discharge, it's always and being one of the most serious apparent manifestations that should warrant medical attention, an assumption that could be a sign of breast cancer. But it's always, we cannot guarantee until we do the biopsy, especially with FNA, fine needle aspiration biopsy study. The nurse is volunteering at a community center to teach women about breast cancer. What should the nurse include when discussing risk factors? So these are the risk factors for breast cancer. So number one, late menopause. Number two, personal history of colon cancer. Nulliparity, another one. What else do you think can be listed under the women at high risk for breast cancer, other than these three risk factors?
Family history of breast.
I'm sorry, history of?
Family history of breast cancer.
Family history, yes. Family history, yes. Yes.
Hormone replacement therapy,
HRT, yes.
obesity, smoking,
Okay. What about
long-term use of oral contraceptives.
and
Post-menstruation before 12.
early menarche, yes. Early menarche and alcohol consumption as well. So women an increased risk for development of breast cancer if they are older than the age of 50, have a family history of breast cancer, have a personal history of either breast cancer, colon cancer, endometrial cancer, ovarian cancer. It's not just colorectal like colon cancer, but any type of cancer other than breast cancer. So also along patients or individuals with or women with a long menstrual history as seen with early menarche or late menopause and have had a first full-term pregnancy after the age of 30 years are all risk factors for breast cancer. The nulliparous also risk factor. Alcohol consumption, risk factor. All these are risk factors. I mean, like, it's, again, risk factors. I mean that immediately after having, experiencing this risk factor that will result in breast cancer. But trying to eliminate the risk factors to reduce the likelihood and the predictability of the breast cancer.
Professor, I have a question.
Yes.
Is it just first pregnancy after 30? How about people, it's not their first pregnancy, but maybe subsequent pregnancies after 30? Are they also at risk for breast cancer?
The false pregnancy? Yeah, false pregnancy is different, but pregnancy itself, not false pregnancy.
Any pregnancy after 30?
After 30, yes.
Okay.
It's it's a full-term pregnancy, not just like, maybe the pregnant and then abortion. That's over 30 years old. It's not considered as a risk factor. But the full-term pregnancy after the age of 30 years, that's a risk factor.
Thank you.
Yeah. Okay. Next question. The nurse performs breast examination on a 68 years old female patient. Which clinical manifestation indicate further evaluation of breast cancer is needed? Now, this is a question I was referring to about the discharge, about the skin or changes, apparent changes that may indicate the breast cancer, or at least reason to seek medical attention or warrant medical attention for breast cancer examination. So the irregular, non-tender lump with induration. Dimpling also is another sign. The orange drainage or secretion. I'm sorry, color discoloration of the nipple. Nipple retraction, another sign. So the lump or that is fixed, it's always considered as could be benign. Most likely it's going to be benign, but the palpable movable lump that is hard or regular, poorly delineated, like there's no any regular shape. It's a regular shape, like poorly delineated, non-mobile, and non-tender. The retraction of the nipple, which is like the orange colored nipple retraction, induration, nipple dimpling of any part of the skin of the breast skin, the overlaying skin, and a dimpling, like indentation. That's also considered as sign of, or one of the signs of breast cancer. We went over the mastitis, and we said mastitis present with breasts that are warm to touch, indurated, painful. That's mastitis. The last one here, when doing a BSE, the female patient should report which finding to the PCP. All what we have just mentioned previously about the abnormal findings from the BSE. In addition, also to, you can add one more, which is the nipple deviation, which is what is called the unilateral deviation of the nipple, may be a clinical indicator of breast cancer, and that can be added to the previous findings. Now, patient is caring for a 52-year-old woman with breast cancer who is receiving high dose of the doxorubicin, which is adriamycin. Now, this slide about two medications, the adriamycin and the other one, just tamoxifen. So the first one is adriamycin. The most important for the nurse to make is a cardiac rhythm. So we have to monitor the cardiac rhythm, because the doxorubicin, especially when it's administered at high doses, it may cause the cardiotoxicity and heart failure, CHF. So the nurse should monitor for cardiac dysrhythmias, EKG changes, and clinical manifestations of CHF. However, that other than the cardiac adverse effects, you may include also stomatitis, which is inflammation of the oral mucosa, alopecia, loss of hair, the medication, the tamoxifen, the next one, the 50-year-old patient on tamoxifen. So most of the questions about tamoxifen, go over the side effects. You will find that's the most serious one is the visual changes. Visual changes. So the tamoxifen has the potential to cause cataract and retinopathy. So the drug also is likely to exacerbate rather than alleviate perimenopausal symptoms. So the perimenopausal symptoms will be exacerbated, not alleviated with tamoxifen. So report any changes or alterations in patients' visual. So this is something that I want to teach the patient about tamoxifen. Anytime, they have to report to the PCP any visual alteration, changes, visual problems, issues that they pertain to vision post being, placed on this tamoxifen. That's the most serious one. Next question is about patient or 67-year-old woman, obese woman, after right mastectomy. So these, the rest of the questions are pertinent to the post mastectomy. So after right mastectomy, also they resected the axillary lymph nodes, being resected or dissected. Post-op discharge instructions should be provided to the patient. What would you teach the patient post-mastectomy?
I just know after it, you don't do the blood pressure
On the right
on
side.
the
Okay.
affected side. You
No
don't
blood
do that.
pressure, no venipuncture, no injections. Similar to the patient on affected side, similar to the patient post with incisional disease when we create the fistula. AV fistula in patients with ESRD, same thing. No blood pressure readings, no venipuncture, no injections on the affected side. Same thing here. So one of the things that can be done is the special massaging therapy. It can decrease swelling in the patient's arm because one of the most significant, I would say, complications that we try or attempt to prevent, which is lymphedema. Read about lymphedema. Very important concept about post-op mastectomy is lymphedema and how to prevent lymphedema. Nursing interventions for prevention of or at least to lessen or to decrease the intensity of the lymphedema post mastectomy. So sometimes they do like specific teaching about the PT and OT. They have a specific exercises to be done post op, and there is some massage techniques to mobilize the sub-Q accumulation of the fluid and prevent lymphedema. The arm exercises should be performed to prevent contractures also, and muscle shortening, maintain muscle tone, and improve the lymph and blood circulation. So the arm exercises that should be initiated right after surgery, post-op, and increased gradually. At the same time, we should, prevent or not doing the actions or tasks that we just mentioned about the venipuncture, the blood pressure reading, and the injections on the affected side. The 24-year-old patient had breast augmentation surgery, and patient will be discharged same day. What instructions should the nurse provide to minimize the risk of complications in the immediate recovery period? So, what do you think post-op? This one very specific to this surgery is that we ask the patient to avoid strenuous exercise during the recovery period. And this is similar also to, and not specific to this, like to this surgery, all breast surgeries, mastectomies, and all belong to, this technique or this prevention applies to all these type of surgeries. So as with all types of breast surgery, strenuous exercise is contraindicated during the recovery period after breast augmentation, as well as post mastectomy. So to prevent because there will be an incision, to prevent the dehiscence and provide comfort, the patient also should be taught to wear the bra, because the bra will be wearing that will prevent the dehiscence and will provide comfort. Now, positioning post-op. Positioning, semi-Fowler's position, it's not necessary actually here. But the most important about the positioning post, not augmentation, but post mastectomy, the elevation of the affected arm on a pillow or two pillows, that's more important than the whole body positioning to prevent the lymphedema. Elevation of the affected arm on a pillow to prevent the lymphedema. That's more important than sleeping in semi-Fowler's position, or it doesn't really matter. It's more of the affected side, affected arm to be elevated, not the whole body. But the most important is that the passive also range of motion exercises should be avoided at first. So other questions about the endometriosis. So the nurses care for a patient diagnosed with breast cancer who underwent I believe we did this one, right? Oh no, very similar to the first question. But what intervention would you do to decrease lymphedema?
You said elevate the affected arm.
Yeah, exactly. So you assess blood pressure only on unaffected arm.
Yeah.
Yeah, blood pressure should be done only. Venipunctures in the unaffected arm. Injections should be on an unaffected arm. So avoid doing any of these things about blood pressure reading, venipunctures, injections on the affected arm. It should be avoided. Post-op, we don't apply any elastic bandage because that could inhibit the lymph drainage. I would like the lymph drainage to continue smoothly to prevent lymphedema and the swollen arm. Affected arm should always be elevated above the heart. When we say isometric exercises, always it is recommended, but again, it should be done gradually increased, starting in the recovery room to reduce fluid volume in the arm. which is lymphedema, to prevent that. The 51-year-old woman recently had a unilateral right total mastectomy with the resection of the lymph nodes. So intervention would you include in the patient's plan of care? I believe that we went over this, which is the to promote a gradual increase in mobility as soon as possible following the surgery. So mobility should be encouraged beginning in the PACU or post-anesthesia care unit and increase gradually throughout the patient's recovery period, because the immobilization is counterproductive to recovery. Patients affected limb or like the arm or the upper extremity affected one should not be in a dependent position. In other words, should not be like on the patient's like bed or mattress or hanging or dangling or like below the patient's waist, or it's always should be above at least at the heart level. So should not be in a dependent position and should always be elevated to at least to the level of the heart. And patient will be on also no need for the diuretic medications to treat lymphedema. Positioning, exercise, activity, special training. Like exercise that should suffice to prevent the lymphedema. The now the nurse answered the call bell. Yeah, read this. This is very important about the one of the techniques or treatment modalities that we reviewed early. The first few slides about the implanted radiation, and this one is when we went over the thyroid, right, and radioactive iodine therapy, and this one is about the cervical radiation implant. So the implant dislodges. Now the implant is just radiation device. It will emit radiation. It's right on the bed. It's right dislodged from the cervix, and now it's in the bed. So after doing all of this, finding that long-handled forceps and pick up the implant and place it in a lead container, that's the appropriate thing to be done, or step one. What will be next step? This is a radiation device, the device that is going to emit radiation. So a lead container, which is always to be next to the patient's bed, lead container, and a long-handled forceps always to be available for that emergency. So now this lead container and this long-handled forceps should always be kept in the patient's room at all times during the internal radiation therapy. Whenever you hear an implant, radiation therapy implant, remember that this lead container and this long-handled forceps to be available. Now, if the implant becomes dislodged, then you would pick up the implant with a long-handled forceps and place it in the lead container. But what's next? There's professionals who are specialized in taking care of these devices and these type of treatments. They are the radiation therapist. So the radiation therapist and the radiation safety officer that always should be notified immediately after that and incident and explain about the situation so that they can retrieve and secure the radiation source back again. Now, also, you should be informing the PCP, should be also called after taking action to maintain the safety of the patients and others. So safety, patient safety and safety to others, number one, and then you call PCP. Now, the 60-year-old woman comes to the clinic reporting unexpected bleeding. What statement should the nurse use regarding diagnosing the cause of the bleeding? The most definitive and the ultimate type of diagnosing and its confirmatory diagnoses will be done by biopsy. Always. That's number one. So endometrial biopsy will determine the cause of the bleeding. So when expected bleeding in a postmenopausal woman, the endometrial biopsy will be done or taken or performed to exclude or diagnose. It's going to rule out endometrial cancer. So hysterectomy only will be done either just hysterectomy or with salpingo, which is fallopian tubes, or oophorectomy, which is ovaries. And when we say salpingo or oophorectomy, means fallopian tubes and ovaries all removed with the uterus. That's hysterectomy with bilateral salpingo or oophorectomy. With lymph nodes, and then we take biopsy. That should be done to treat endometrial cancer if diagnosed. The pap smear, I think we have a question. We answered one of the questions in class, Q&A questions. The pap smear, first of all, will not diagnose endometrial cancer unless it has spread to the cervix, become like cervical cancer. Second is that the pap smear is not required after the hysterectomy with the salpingo or oophorectomy, no need for the pap smear. And lastly is the list of the medications to review and make sure that you go over the at least side effects, indications, off-label uses, if there is any, and nursing implications for each one of these medications. So let me stop recording.